Hello everyone. One more lecture for thyroid conditions, and today we are going to start with thyroiditis. And as you know, what is thyroiditis? It is simply inflammation of the thyroid gland. Now, like in my previous lecture, as I told you guys that whenever there is inflammation in the thyroid, so what will happen is the thyroid cells are going to get inflamed, and once they are going to get inflamed, so all the thyroid hormone which is inside the thyroid gland, they are going to spill out in the blood. So whenever there is thyroiditis, um, the first phase will be increase of thyroid hormones in the blood, which is going to give a clinical picture of hyperthyroidism. We can also say this stage as thyrotoxic stage. And once that thyrotoxic stage is passed, then of course the thyroid, which is inflamed, it cannot make more thyroid hormones. Then the patient is going to go in hypothyroidism. Now, as I told you already in the previous lecture, that what are the features of hyperthyroidism and what are the features of hypothyroidism. So, we are going to see the clinical side of this thing. Whenever we see any patient, what we see is we check the thyroid status, like either the patient is in hyperthyroidism or either the patient is in hypothyroidism, yeah, which I already explained you in the previous lecture, that in hyperthyroidism the patient will be restless, and there will be increased pulse, there can be tremors, the patient can complain of diarrhea, not sustaining summers and all this thing, whereas in hypothyroidism you can find that the patient have increased BMI. Also the patient may have you can say slowed reflexes, cannot stand cold weather, constipation, decreased appetite, and weight gain, whereas in hyperthyroidism there will be weight loss. So now, what is thyroiditis? By definition, it's very easy. It's inflammation of the thyroid, and there are different type of thyroiditis. It can be caused by different conditions. For example, like it can be simply divided into two main categories. One is called as painful, and one is painless thyroiditis. I'm going to show you here. So, painful thyroiditis, it is also called as D. Quervain's or granulomatous thyroiditis, whereas painless, there is the other type is painless thyroiditis. So simply when the patient will come, depending on the stage which on which patient is coming, it can be hyperthyroid stage or it can be hypothyroid stage. But on clinical history, we can simply ask the patient either it's painful or painless, and on examination, we can examine the thyroid, we can palpate the thyroid, and we can see if there is any tenderness in the thyroid or not. So, simply, all this thyroiditis, it is defined as acute inflammatory disorder of thyroid gland. There is initial thyrotoxic state, and later on the patient can go to hypothyroidism, and after few weeks or few months the patient will come back to you can say normal thyroid, which we call it as euthyroid. I can like the clinical history goes in this way, that as soon as the patient they go into thyroiditis, okay, the initial stage will be hyperthyroidism, and which is also called as thyrotoxic stage. Then they will go into hypothyroid, state, and later, after weeks to months, depending on every patient, they will become like the thyroid level in the body, in the blood, will become normal, and the patient will be clinically asymptomatic. We also call this thing as euthyroid state. Okay. So coming back to the main discussion, it could be painful, it can be painless. Like as you can see, what are the causes of painful? It could be due to viral upper respiratory tract infections, and it could be painless, which can be postpartum, like after giving birth, could be autoimmune conditions, and could be other lymphocytic. Okay, and now the most common cause of thyroiditis is called as Hashimoto's thyroiditis. Of course, it is named on the person who defined. I think it's Japanese person who defined this state, this disease or condition, and it is that's why it is called as Hashimoto's thyroiditis. So moving on, we already talked about the clinical features, and like you know the clinical features of hyperthyroidism, and you know the clinical features of hypothyroidism. So simply, how we diagnose this condition is simply by asking for like taking history for any viral infection, recent upper respiratory tract infection. We can check for autoimmune conditions, and we can like, for example, if the mother have recently given birth, so of course that will point towards postpartum thyroiditis, and depending on either it's painful or painless, we can easily reach to the you can say the final decision. And now, I will talk about postpartum thyroiditis a little. Like after giving birth to the baby, around 2 to 3 months after that, the mothers they enter into hyperthyroidism state or thyrotoxicosis, and which is followed by a hypo. Like this stage after giving birth, you can say this stage comes back after after 2 to 3 months. Okay, 2 to 3 months, and um, later on, this one is followed by a state of hypothyroidism state, which lasts for 4 to 8 months. Okay, and after that, of course, the patients will go into euthyroid state, depending on every patient. Okay, so simply depending on the patient, either they are coming in hyperthyroidism state or hypothyroidism state. Like as you guys know, we already discussed the thing that the best test to check for the thyroid function, thyroid state inside your body is of course checking the TSH. So for example, if the patient is coming in hyperthyroidism state, the TSH will be lower. If the patient is coming into hypothyroid state, you will find that the TSH is higher. Why? Simply the thyroid is malfunctioning. It is the organ which is affected. So the pituitary will keep on releasing thyroid stimulating hormone, but the thyroid cannot make the hormones, and that's why there is no feedback mechanism. So that's why TSH will be raised or normal or higher depending on the state you are checking the patient, and you can check T3 and T4 levels, okay, in the blood. You can check radioactive iodine uptake. I already explained all these things before. Okay, especially whenever it is like due to some infection or inflammation, one of the tests which I love to talk about is ESR, or erythrosedimentation rate, or CRP, that is C-reactive protein. So they will be elevated as well. So simply like this is a brief introduction about, you can say, thyroiditis, and we will talk about more about Hashimoto's thyroiditis in this lecture. Okay, so whatever thyroiditis is there, how we are going to treat that, like the things makes sense. For example, if the patient have pain, so what you will give them? You will give them NSAIDs, which are given for to anyone who present with inflammation or pain. Okay, Um, Sometimes they give patient, you can say, steroids as well. Okay, so this thing is there, and simply depending on, for example, the patient is coming into hyperthyroidism state, then of course you have to control the symptoms. You can give beta blockers, which we have discussed in the previous lecture. And if the patient is coming into hypothyroidism state, then what we are going to give the patient, that is thyroxine, which we have already discussed as well. So that's like pretty much about like the introduction about, you can say, thyroiditis. Now, like talking about Hashimoto's thyroiditis, for example, we will move further. So, as I told you, what is Hashimoto's thyroiditis? That this one is the most common form of, you can say, primary hypothyroidism. Okay, in the patients, and that's why this condition, like this thing, gave this condition a little importance. So, it is the most common form of primary hypothyroidism, and it is first defined by the guy whose name was Hashimoto's. Okay, as you can see, the most common cause of thyroiditis, and it is also referred as chronic lymphocytic thyroiditis. Yes, guys, this is a chronic condition. Okay, and see, like, this is name on the guy in 1912 who described this condition. Anyhow, I will talk a little about the incidence of this condition. Guys, as I already told you, that all these thyroid conditions are more common in females than males. So this one is very much common in females, 7:1. Okay, it is 7 times more common in females than males, and um, there is again some connection, or they found that, um, sometimes you will find the family history of autoimmune conditions. Cigarette smoking is also a risk factor for this condition. Um, Cigarette smoking. Okay, so cigarette smoking is also a risk factor for this condition as well. And stress as well. So, like, they found that this condition is more common in people who have Down syndrome or Turner syndrome, like this condition. So, simply, it is chronic. It can be defined as chronic autoimmune thyroiditis. Okay, chronic autoimmune thyroiditis. It's a chronic condition. It's autoimmune. Okay, and yes, you can see, like, there are reports that, again, HLA-DR3, which are human leukocyte antigen, or MHC complexes, they have some link, but the association is weak. So that's why, like, it is not so important. Pathogenesis is simply, guys, if I will talk about, uh, if you know about immunity, so both cellular and humoral immunity, they play a role, and what they do, like, both this immunity, they destroy the thyroid gland, and once the gland is destroyed, or thyrocytes are destroyed, so remember, the ultimate result of all the chronic inflammations is fibrosis. So, uh, by our knowledge, we know what is cirrhosis. Cirrhosis is the fibrosis of the liver. As well as in respiratory conditions, we already have gone through that condition called as interstitial lung diseases, in which there is fibrosis in the lung. So whenever there is chronic inflammation going on in the thyroid, it is going to give fibrosis. And remember, whenever in the body any tissue is chronically inflamed, even the skin, if it is chronically inflamed, the tissue is replaced by fibers, so we call this condition as fibrosis. So when the fibrosis is going to happen, so what will happen, that the thyroid cannot function, cannot make thyroid hormones. So again, like, this one is the explanation of the pathogenesis. how the cellular as well as humoral factors they destroy the thyroid gland. The morphology, you can see that the thyroid is diffusely enlarged, the capsule is still intact. Okay, like for example, if it is some sort of carcinoma, the capsule is will not be intact, rather it will be infiltrated by carcinomatous cells. And again, morphology, microscopic examination. Okay, so now like as we are studying this thing from clinical point of view, so when we are going to examine the patient, of course either we will find the features of hyper or hypothyroidism depending on which state the patient is coming to you. And the second thing which we will get is when we will examine the thyroid gland of the patient. Of course, it can be enlarged because there is chronic inflammation going on. Sometimes the thyroid, um, when you will try to palpate that, you will found that the thyroid is rubbery, like rubber-like in consistency. So this thing is the main thing. So all the symptoms which you can find over here, I don't think so we are going to go, we have to go to in details of that, because you already know from your knowledge what are the symptoms and signs of hyper and hypothyroidism, which I already explained in my previous lecture. Diagnosis for this condition. um, okay, so like they are talking about the different types of thyroiditis, okay, which can be caused by many things, as I told you. It could be postpartum, it could be Hashimoto's, it could be viral infections, it could be due to radiations, it could be due to different drugs. There are different types of what you can say causes of thyroiditis. The main thing is the final result, that the thyroid is inflamed, and the thyroid is fibrosed, and this thing. Of course, like in other type of thyroiditis, like postpartum, as I was talking about, it's not, it doesn't run too much long course, so that's why there is hyper, then hypo, and then back to normal. Whereas in Hashimoto's, because it's autoimmune, so what happens, by the way, that there will be hyper and then hypo, and that hypo stage is going to continue because there is fibrosis. So any condition, for example, if some patient have radiations to the thyroid, what is going to happen, that radiations are going to destroy the structure of the thyroid and will change it into fibrosis. So simply due to that fibrosis, the thyroid will not work anymore, and simply the patient will stay in hypothyroidism state for the rest of his life. Treatment we will discuss in a while, but this is the same thing, which I was explaining you before, like thyrotoxic stage, and then there is hypothyroid state, and then coming back to normal. Whereas in Hashimoto's, what is going to happen because of fibrosis, when the patient will come to this state, of course, it is going to run for maybe forever, okay, and the patient will remain hypothyroid until and unless you are going to treat the patient with the medications. um, Talking about the treatment, as I'm sorry, as I already told you that first one is symptoms. Of course, if someone have pain in the thyroid, or it is painful type of thyroiditis, like dequervain thyroiditis, or due to viral infection, simply you can give them NSAIDs, you can give them prednisolone. And if it is hyperthyroidism state, then what you can give them, in my previous lecture I already told you, we will give them treatment to relieve that, okay. And if the patient is coming into hypothyroidism stage, which in Hashimoto's, the patient will stay in hypothyroidism state for the rest of the life. So you have to give what? Lifelong thyroxine therapy. Okay. So of course, and one very important point I should explain here is whenever we put anyone on thyroxine, of course we have to monitor the patient, like either his thyroid levels, hormone levels in the blood are fine, It should not be like more or less. So one thing is, of course, symptoms. If the patient have any symptoms of hypo or hyperthyroidism or not, but the best thing to check either you are giving correct level or correct dosage of thyroxine is to perform TSH levels. Okay, so we monitor the patient. Simply, the point here to remember is we monitor the patients by checking by checking their TSH levels. Okay. I think by now you must know, like, if the TSH level will come back high, it means there is less thyroid hormones in the blood, which means you have to increase the dosage of thyroxine. And if the TSH level is less, which means you are giving too much thyroxine, so you must reduce the dosage of thyroxine. Again, refer my previous lecture if you have any difficulty to understand that. So this is pretty much about Hashimoto's thyroiditis. That is the thing you should know. Um, and rest is like all explanation of this thing. Lymphocytic thyroiditis. It is self-limited disease, as you know. What we are going to found is antibodies. Yes, again, one very important point which I forget to mention. Investigations will remain same. The only investigation which you have to do to diagnose Hashimoto's thyroiditis is, I'm going to add it over here, is you will found anti thyroid peroxidase antibodies. Okay, they are also written as TPO-AB. So what we are going to find in the blood is anti-thyroid peroxidase antibodies, okay, which are circulating in the blood and um, causing this condition. Sometimes thyroglobulin antibodies are also present in the blood. Okay, thyroglobulin antibodies are also present in the blood, which are also written as TGAB, thyroglobulin antibodies. Simply, these antibodies will keep on circulating in the blood and are going to damage the thyroid. Okay, so let's move on. Postpartum thyroiditis, I already explained you this thing. It occurs in the females after giving birth to the baby. And the difference between Hashimoto's and this one is what? In this condition, they return to normal state. Okay, whereas in Hashimoto's, because it's chronic inflammation, they don't return to normal state, and we have to give them thyroxine lifelong. Okay, so overactive phase. Okay, this is all the explanation of that thing which I have already done. Thyroiditis can also be caused by infections, as I told you, viral infections or bacterial infections. Of course, if it's viral infection, we have to wait. Viruses go away by itself. If it's a bacterial infection, we have to treat it by the help of antibiotics. Plus, if there is any pus, we have to drain that. So this thing, drug-induced thyroiditis. Of course, the condition will remain same, thyroiditis, which we are already discussing. But what are the drugs which can damage the thyroid? You can see amiodarone. This is the drug which is given to many patients who have arrhythmias. Lithium is a drug which is given to many patients who have bipolar disorder, a psychiatrical disorder, mood disorder simply. And this lithium is given for a long period of time, and that's why they can cause side effects like this. Interferon, cytokines, they are used in treatment of many viral conditions like hepatitis B, C, and many other conditions. Radiation induced thyroiditis, again, many people who receive radiations for the treatment of cancers or things like this, they can, like the radiations, they can damage any organ. Of course, they can damage um, thyroid gland as well. And once the thyroid gland is damaged, the patient will go into hypothyroidism. Okay, so This one is not so important, but it's written over here, so I'm going to explain it a little. You can see Riedel's thyroiditis. So, what is this one? That as you can see over here, that the normal thyroid parenchyma or the normal thyroid tissue is replaced by fibrosis. Okay, and that fibrosis, uh, see, extends beyond the thyroid capsule. So I think now you can understand what is the condition behind, what is the difference between Hashimoto's and this one. Is that in Hashimoto's the capsule is intact, whereas in Riedel's thyroiditis it is going to extend beyond the capsule. And on clinical examination, when we try to palpate the thyroid, we found that the thyroid is stony hard. Okay, and see, because it um, damages, or it uh, you can say invades the adjoining structure. So anatomically, thyroid is placed in front of trachea, and behind trachea there is esophagus. So this Riedel thyroiditis can simply involve the trachea or esophagus, and it can cause obstruction. So most of the patients who have renal thyroiditis, it simply needs surgical management to relieve that obstruction, because it could be like life threatening. Okay, so this one is like all which I already explained. If there is thyrotoxicosis, what you are going to do? You are going to control the symptoms. Okay, beta blockers, thyroid limiting drugs, previous lecture. If the patient come into hypothyroidism state, giving thyroxine will solve the problem. If the patient have pain, NSAIDs are going to help. Okay, so the explanation of the same thing. I'm recording this lecture so you can stop here, read. Maybe you will not find anything more, okay, which is already discussed. Okay, one very important thing to know here is toxic adenoma. What is toxic adenoma? Um, Sometimes a small nodule in the thyroid it can develop, and what happens that this small nodule can overproduce, or can be a hyper functioning type of nodule which keep on producing T3 and T4. So what will happen? The patient will go into hyperthyroidism state. Okay, it could be like a single toxic adenoma. It could be a multiple, like too many nodules. In that case, it is called as multinodular goiter. Okay, so and whenever it is like multiple nodules, we also call this condition as plumber's disease. This is the other name of this condition. Not so important, not so high yield from different exams point of view, but you can say another extra piece of knowledge. So I'm not going to go in again into detail of that. Like, whenever it is hyperfunctioning, there is more T3 to T4 in the blood, and the patient is going to show the picture of hyperthyroidism. And clinically, when you are going to examine that patient, uh, the patient will be having the features of hyperthyroidism. And if the patient have the features of hyperthyroidism, what can be done? PTU, MMI, PTU or MMI, you can say. Okay, propyl thiouracil or methimazole. Okay, and why we give that? Just to bring back the thyroid to normal, thyroid hormones to normal. Okay, or euthyroid state, normal. Okay, so this is the thing. If there is too many symptomatic like symptoms like um, increased heart rate, palpitations, tremors, you can give them beta blockers to stop the sympathetic activity. Um, what is the ultimate treatment if it is not treated by this one? Surgical excision of that nodule. And of course, like before surgical excision, what they do, they run some test, that is, iodine uptake, and they can see the areas where iodine uptake is more, so that they can like excise that areas. Thyrotoxic crisis or storm. Okay, this is a interesting condition. See, as we know, there are two conditions: hyperthyroidism and hypothyroidism. So, um, what is the point to learn here is sometimes when you can say there is acute exacerbation of symptoms of hyperthyroidism or thyrotoxicosis. We call this condition as thyrotoxic storm or thyrotoxic crisis. So, see, acute exacerbation of all the symptoms of thyrotoxicosis, presenting in a life threatening state secondary to uncontrolled hyperthyroidism. It's a medical emergency. Any patient who have thyrotoxic storm, any patient who have thyrotoxic crisis, they both are same things. Um, of course, it can be life threatening. Now, in what patients this thing can occur? All the patients who have hyperthyroidism, um, whenever they have some infections or trauma, surgery, for example, is a trauma as well. So you can say there is too much thyroid hormones in the blood, which can cause this thyrotoxic crisis or storm. Now, for example, whenever the patient will go into this thyrotoxic courses, what will happen that the blood pressure will increase, the temperature will increase, there will be more sweating, there will be more tremors. So this condition can be confused with many other conditions. For example, one condition which we will study is called as pheochromocytoma. Okay, so pheochromocytoma. Pheochromocytoma is the tumors of neural crest cells which keep on producing epinephrine and norepinephrine, and the effects of epinephrine and norepinephrine are simply same, like the thyroid hormones. So pheochromocytoma and conditions like, you can say, many drug abuse, like cocaine. When the people they smoke cocaine, what happens that they get tachycardia, they get increased temperature and all this stuff. So this condition can be confused with this condition. So you can say like these malignant hyperthermia is also there. These conditions are very important DDs. Okay, differential diagnosis. Like simply, doctors can confuse this condition with these conditions. Okay, so simply, as I told you, the patient can present with too much increased temperature of the body, like hyperthermia. Sometimes the temperature goes more than 40 degrees centigrade. They will present with tachycardia. They will present with diarrhea. Uh, they will be confused. It can lead to shock. It can lead to arrhythmias. It can lead to delirium. It can lead to coma. It's a life threatening condition. The mortality is also high. The mortality is somewhere around, you can say, um, around 10 to 30%. Okay, which means like all the patients uh, who will develop this condition, there is like out of 100, you can say 10 to 30 patients they die. Okay, so like in emergency, quickly we can do labs, we can check the levels of thyroid hormones in the blood. Okay, and how we treat this condition is also important to know. How we treat this condition is by giving fluids to the patient. Okay, we give them cooling blankets to decrease their temperature, body temperature. You can give them antipyretic drugs, paracetamol, like acetaminophen. They have too many symptoms like tachycardia, arrhythmias, so again, beta blockers can be given to them. Okay, and that's it. Okay, rest is of course like the same things. Like once the patient condition is controlled, you can put them on PTU, propyl thiouracil. Okay, um, and sometimes, of course, it's a life-threatening condition. The doctors can give them steroids, dexamethasone by IV, of course, because it's an emergency. Okay, and with PTU, one more thing which we can give in emergency to these patients is um, we can give them iodides. Okay, so what iodide? Like we can give them sodium iodide or potassium iodide. Okay, so what iodides do, by the way, they inhibit um, the release of thyroid hormones. Okay, so like this is the treatment of this condition. On the other hand, when we are going to study hypothyroidism, see, thyrotoxic crisis or storm is one of the extreme whenever the patient have hyperthyroidism, and it is like the hormones are forming too much. It can lead to thyrotoxicosis or thyrotoxic storm or crisis. On the other hand, whenever the patients have hypothyroidism and it will become again severe, the causes are same due to any infection, trauma, sepsis. See, many things are written over here. Myocardial infarction is also a kind of trauma. Okay, so again, the patients can go into a condition called as myxedema coma. So myxedema coma, uh, again, why these conditions are important, guys? Because the mortality is really high. This condition have mortality up to 40%. So out of 100, many patients die. Okay, once they develop this condition. So see, it's written up to 40% despite therapy. Like even if you're going to give treatment to them, um, the mortality is really high. It's rare, but high level of mortality whenever it occurs. So now, the important points behind, like for this condition, I will tell you. Think about hypothyroidism features. I will talk a little about hypothyroidism in my next lecture as well. See, the patient will present with hypothermia, hypotension, hypoglycemia, hypo heart rate, or you can say bradycardia. That is the correct word. Hypoventilation. Okay, so in that case, the patient is going into hypers. In this case, the patient is going into hypos, and again, the mental status will be disturbed. Simply, they can go into coma. So there are different differential diagnoses for this condition, but I don't want to put you in that discussion right now. All these patients, they need ICU admission because the mortality is really high. We give them corticosteroids, which are also called as corticosteroids, which are also called as life-saving drugs. Plus, what should be given? It's a hypo condition. We must give them thyroxine. Okay, and whenever it's an emergency, guys, thyroxine IV, corticosteroids IV. So simply thyroxine IV, corticosteroids IV, and rest is all symptomatic treatment. For example, if the patient have hypoventilation, we can ventilate them by the help of ventilators. If their blood pressure is too much low, we can give them drugs like vasopressors. which increase our circulation, or you can say which maintain or try to maintain the hemodynamics, like dopamine, butamine. Okay, you can simply give them IV fluids simply to maintain their blood pressures. And yes, so that's all about the treatment for this condition. So this is like myxedema coma. I think like I will go revise a little. See, have we already discussed hyperthyroidism? We already discussed in the previous lecture what are the causes of hyper as well as hypothyroidism. What are the clinical features of hyper as well as hypothyroidism? Then I talk about a condition which can cause inflammation to the thyroid, like Hashimoto's, lymphocytic, postpartum, radiation, Riedels. And right now we are discussing the conditions like what will happen when there will be too much thyroid hormones in the body, like excessively and suddenly thyrotoxic courses or thyrotoxic storm or crisis. What will happen when someone have hypothyroidism and they are going under some stressful condition? They can go into myxedema coma. So this is like about all about the things we have covered. Now I will like to talk about um, okay, before finishing this lecture, guys, goiter. What is goiter? Goiter is simply um, whenever like anyone thyroid gland is increased in size, okay, or simply you can see it clearly. What you can say clinically, okay, that is called as goiter. So goiter can be toxic or it can be non-toxic. Okay, I already talked about that toxic nodule or toxic multinodular goiter. Uh, Simply, we call it as toxic when it is hyperfunctioning. And for example, if there is a nodule, a goiter, too many nodules, which is increasing the size of thyroid, and it is not hyperfunctioning, rather, it's a non functioning type of nodule, then we call it as what? Non toxic. So, non toxic goiter patients, of course, you will, like toxic goiter patients, you will always found them. Clinical picture will be simply hyper state. Whereas non-toxic goiter, the condition will be not hypo but euthyroid state, because their thyroid gland is functioning well. Okay, the only issue is what, like they have nodules which are not functioning, so simply they will be euthyroid. Okay, so this is called as non-toxic goiter. Now, like one of the cause, by the way, there was a big campaign which was run many years before. Now everyone knows, like the iodine deficiency can give you goiter. So of course, non-toxic goiter, a very important cause is iodine deficiency. Okay, and there are some vegetables like turnip. It is considered as goitrogen. Simply like this is what you can say, one of the vegetable which can cause goiter. Many drugs are also can also cause non-toxic goiter, like lithium again. Okay, so simply how we treat it, if there is iodine deficiency, guys, give them iodine. If they are using any goitrogen like turnip, stop that. If they are using any drug, like I gave the example of lithium, stop that. Okay, and what you can say, if the goiter is too big, okay, if the goiter is very much in size that it is causing you can say symptoms, Okay, then of course we do surgery and remove that. Okay, so surgery only whenever there is compression symptoms. Because whenever the goiter is too much enlarged, it can compress the structures like trachea and esophagus. That they are very vital structures, and they, like, the patient compromise can be airway compromised, airways can get compromised. So that's the reason um, surgery is required to remove what you can say, to remove this goiter. Okay, surgery is done. Surgery is done for these things. So if you are talking about nodules, so how to approach a thyroid nodule whenever a patient comes, the first thing we do is we check the TSH level. If TSH is elevated, it means the thyroid is hypofunctioning. We do biopsy of that because it could be malignancy, it could be any condition. Thyroid malignancy, when you will study in surgery, you would know that there are many types of thyroid cancers like papillary thyroid cancer, medullary thyroid cancer, follicular thyroid cancer. So whenever the thyroid is hypofunctioning, what we do, by the way, is we do go for biopsy. Low TSH means the nodule is hyperfunctioning, we go for thyroid scan. Okay, on thyroid scan, if it's a cold nodule, or you can say a hypofunctioning type of nodule, okay, we again go for biopsy. See this one. But if it's a hyperfunctioning type of nodule, we don't go for biopsy. But what we do? We treat hyperthyroidism. What's the point to learn here? The point to learn here is most of the hot nodules or hyperfunctioning nodules are not cancers. That's why whenever we found a hyperfunctioning nodule in thyroid, okay, we know they are mostly not cancers. So we simply treat the patient's symptoms. We treat hyperthyroidism. But whenever we found a nodule, see here or here, which is not functioning. Not functioning means what? Not producing any um, thyroid hormones. We call it as a cold nodule or hypofunctioning nodule. There are higher chances that it could be malignant. Okay, it's not. I'm not saying that it is always malignant. I am saying there are higher chances that it could be malignant, and that's the reason um, we go for biopsies. Okay, so like nodules can be cancerous or malignancies can be a simply nodule, um, can simply a cyst. Okay, can be anything, but the rule is what? Whenever the nodule is hyperfunctioning, we treat that because the risk of carcinoma is very low. But whenever the nodule is hypofunctioning, we always go for biopsy. Biopsy to rule out um, what you can say, malignancy. Okay, so that's all about thyroiditis as well as how we deal with nodules. And hope you like the lecture.